Hello and welcome everybody to this episode of the Asthma Spotlight podcast. I'm absolutely delighted today to be joined by my colleague, Professor Andy Bush. Andy, hello. Um,
Hi.
I'm delighted to welcome you today. Why don't you introduce yourself and tell us about who you are and what you do?
I'm Andy Bush. I work at the Brompton Hospital. I just see children with respiratory problems. I also do research at Imperial College. My big interests are in monitoring asthma, early life influences on asthma, and my biggest interest of all is my 8 grandchildren.
Delighted to hear that. Okay, so Andy, to start off with, I know we've spoken quite a lot about pediatric care versus adult care of asthma. So could you tell us a bit about what your thoughts are on the quality of pediatric asthma care in the UK, and also maybe some examples from other countries in the rest of the world?
Although there's no doubt in the UK that there are islands of really very good practice in primary and secondary care, there are also areas where things are not good in pediatric asthma. The basics are not got right. The whole thing is trivialized. Asthma attacks are not taken seriously. All these things need attention. And for me, part of the trouble is I can call myself an asthma doctor and set myself up as an asthma clinic without, as far as I know, having to undergo any discernible training at all. I can just say I'm an asthma specialist.
That's a key problem and is a great concern, really, because especially in the UK, we've got so many people being treated for their asthma by, or being delegated to be treated for their asthma by people who don't have adequate training, sometimes not even any training in asthma care. And this is a great concern. Can you give examples of good asthma care for children in the UK and also in other parts of the world?
Yes, I'm afraid I'm not terribly familiar with a lot of care systems in other parts of the world. I'm in the UK, as opposed to low and middle income countries. We have free access to all the medications we need, which is fantastic. And there are undoubtedly good asthma clinics where children are seen regularly, where the appropriate measurements are made both for diagnosis and management. But some of the problems are that management is based on a diagnosis that is wrong. And people think, oh, I can diagnose asthma without doing any tests. Can you name me any other chronic disease where it's possible to do tests to support the diagnosis before committing somebody to medium to long-term treatment, and those tests aren't done? It just makes no sense. The other really important thing, and parents, if you're listening, what you really need to know is who is responsible for your child's asthma. Too often care is fragmented, and this is not meant as a shot at the GPs or anything like that. It's the way things are. Your child may see somebody with an asthma attack and never see them again. There isn't that continuity. And you need to have somebody who's taking a life course view of your child's asthma, who is responsible. For sure, they may not see that child every single time. That's the way of things. But who is the captain on the bridge? Who is responsible? That is the question. If I was a parent with a child with asthma, I would be asking.
That's such a fantastic point, really. I have addressed this in previous podcasts and tried to encourage people, parents of children, to learn as much as they possibly could about their asthma. And also,
Definitely.
yeah, and when I interviewed Bev Bostock, who's a specialist respiratory nurse, she advised parents to ask the healthcare professional that's seeing them whether they have been trained in asthma care or not, which I think is a good question to ask.
Certainly.
Primary care. Okay, so I know we've spoken a bit about inequalities in care in children with asthma. And as a general practitioner, my problem has always been difficulty to find specialists who are pediatric experts in asthma where I can refer children to. What are your thoughts about this, where healthcare resources seem to be focused more on adults than in children?
Yes, it's very frustrating, Mark. There is no question that adult asthma is a very different ballgame. To take something that is obvious and can be measured, if you look at the studies that are done in the new asthma treatments in adults as compared to children, they are overwhelmingly done in adults, and the children are the forgotten sort of add-ons. You can manage them. This is the way we manage adults, so you can manage children the same way. Well, that's just not good enough. I would not be happy for my 6-year-old to be managed the way you might manage a 66-year-old. It just doesn't make sense. So there's that inequality. There's also inequality of access to care, and child poverty is clearly also a big factor in accessing care. Expectations, parental expectations. What do they want? Are they actually being demanding and pushing for the better care? My wife, before she retired, was a physiotherapist in neurodevelopment, and she used to say to the mothers, unless you've got a reputation for being a thoroughly disagreeable mother, you're not doing your job properly. I'm afraid you're right. The shy retiring pilot gets nothing.
Can I come back to a point you made earlier? Why do you think that diagnosis of asthma in children is delayed for such a long time? I mean, I've got experience in primary care of seeing children who have been transferred to my practice, where children have obviously been coughing and wheezing for many years, and nobody's written the word asthma in their medical records.
Yes, it's extraordinary, isn't it? I mean, I think part of this problem is the lack of a will to go on to investigate the coughing child. And I don't mean sending them to hospital. I mean doing certain simple things that can be done in primary care, like measuring their peak flow. You can order a chest x-ray. Failure to appreciate the red flag symptoms, like a chronic wet cough, which is not due to asthma. And I see asthma, as well as you say, with a big diagnostic time lag. I also see children diagnosed with asthma who basically no more have asthma than I do. And we've got to get it right both ways. And what we've really got to get into our heads, I think, is that it's not good enough in 2023 to sit behind a desk, whoever you are, and just talk to the mother, and on the basis of a bit of chit-chat, say, your child's got asthma, your child hasn't got asthma. Asthma is a serious condition, and we've got to get that into our heads. And missing the diagnosis is a problem, and overdiagnosis is a problem.
I suppose one of the difficulties, and I had a letter from a general practitioner the other day who listens to the podcast, and he's caring for a young child, 6-year-old child, who has a history very suggestive of asthma. Dad's got asthma, and the child's had a previous history of having had eczema, and the child's also recently needed nebulized treatment for an acute wheezing episode. Now, how would you advise doctors who are having difficulty in, well, first of all, the doctors in having difficulty in making the diagnosis and persuading parents that their child might have asthma? I'll come on to the next question in a moment, but let's start with that.
Again, I think in terms of assessing symptoms, one of the things that all of us do badly, including me, is use mobile phones. It's really helpful if there's a doubt, because the word wheeze is often used very imprecisely. Clearly, if the child is ill and distressed, the mother shouldn't be reaching for a mobile phone to make a recording. But if you can get a recording of the noises that your child is making, that to me is incredibly valuable. So is this the true whistling polyphonic expiratory wheeze like that, or is this a different noise and need a different approach? So I first of all be really sure this is wheeze. For a 6-year-old with a bit of tuition, you ought to be able to get a peak to do peak flow monitoring, and just see, do a peak flow in the surgery. Give the child some short-acting beta agonists through a spacer. Now, if the peak flow is normal, there won't be any change. Send the child away with a peak flow meter for 2 weeks, no more, because everybody gets bored after that time, and say, can you do it morning and evening? And at the weekend, not at school, because it's too much for the school, if they're running around and getting breathless, do a peak flow afterwards. Do a peak flow if you're going to give the child some short-acting beta agonist, and see if it improves. These are the sorts of things you can do in primary care and in secondary care. Ultimately, it may be that you have to do a therapeutic trial and say, well, look, we're going to try for 6 weeks or whatever arbitrary time frame with an inhaled steroid. If they don't we'll stop at 6 weeks, because either they're better, and you don't know whether it's because you're a frightfully clever doctor, or they're going to get better anyway, or they're not better and there's probably not asthma and you need to look elsewhere. And then you only restart the treatment if they've got better and relapse when the treatment is stopped. Those are sorts of approaches that I would take. In an older child, if you've got access to things like exhaled nitric oxide, that's good. But not everybody has access, and it would be ridiculous to say you can't diagnose asthma without an exhaled nitric oxide. But I think the principle that you should be doing some tests and finding out what's going on is a good one. And the more tests that are negative, the less likely the asthma diagnosis becomes.
Thank you. That's a very helpful description, which I'm sure healthcare professionals and patients will find useful. Can you tell us a bit more about nitric oxide? Because I'm a bit concerned that it's being used as the ultimate test for asthma. And my colleagues are being taught that you've got to do nitric oxide and spirometry to diagnose asthma in anybody. If you haven't done those, then you can't make the diagnosis.
So nitric oxide is one of many tests that can be helpful, but as you know, Mark, there is no one diagnostic test for asthma. No one rule in, rule out. It's not like TB, where if you see the acid alcohol fast bacilli in the sputum, you know where you are. So nitric oxide can be elevated in uncontrolled asthma. It can be elevated in those who have atopic disease, such as eczema, or without having asthma. My best use of it, I think, is if I'm seeing somebody who people are thinking have asthma, is having a lot of symptoms, and the nitric oxide is completely normal, that to me is a red flag. If the nitric oxide is high, it's a supportive of asthma, but it's not diagnostic. And again, the art of the possible. A 6-year-old may well have atopic, allergic, type 2 inflammation-driven asthma, but be unable to do spirometry and be unable to do nitric oxide. Now, neither of us would just sit on our hands and say, we'll come back in 2 years' time when the child can do these tests. That would be absurd. But I think always, and again, parents, ask your doctors what tests have been attempted to try to document the diagnosis of asthma. If you attempt and fail, well, so be it. Try again in 6 months' time. But note down that the diagnosis of asthma is only based on a history, which may or may not be correct.
Thank you. Thanks. That's very clear. So, okay, so in a child that has been diagnosed, and this was the other question that the doctor asked me, although he hasn't really confirmed the diagnosis yet. Let's say a child has been diagnosed with asthma. We know that we've both probably had experience of many patients and parents who are reluctant to take inhaled corticosteroids for their children. Now, how do you explain to a parent, or what sort of objections do you hear from parents? And how do you explain to parents that anti-inflammatory treatment is really important in the management of asthma, and even in trying to make a diagnosis of asthma?
Yeah, I think it takes time. And I think parents, quite rightly, do not want to give medications to their child. No mother or father wants to do that. I think it takes time. You hopefully, by discussion with the parents, saying, okay, maybe even for a short trial. And flipping back, Mark, to what we were saying about children being left out, increasingly, as you know, GINA is recommending for 12 and over, instead of using the blue one, the short-acting beta agonist, the Ventolin, you should be using a combined inhaler of formoterol and budesonide as a reliever therapy. And I don't know if we've got time to go into the advantages of this, but they are very clear-cut, and I'm completely behind GINA. But 6 to 11.
Sorry, Andy.
Yeah.
GINA, of course, is the international document for asthma. Sorry, please continue.
No, absolutely. And they're a widely respected body with people drawn from all over the world. I think they even include you, Mark, don't they? But no body is perfect. But this is where there aren't the data in children 6 to 11. Now, there are studies ongoing. There's one in New Zealand that's finished recruiting. Louise Fleming is heading up a study in the UK. But actually to say, if to use the combined inhaler, there's lots of data that using the combined inhaler, and that may be an easier sell to parents, saying, look, just give this inhaler when your child needs it. And hopefully, if your diagnosis is right, hopefully they will see when treatment is given, it works. And if I could interject, one of my own sons was diagnosed with asthma when he was 3, and I should, in all humility, say that I missed the diagnosis. I thought he was malingering. These were the days really before inhaled steroids were so front and center. He was trialed on various things like theophylline and Intel and that stuff. When he started low dose inhaled steroids, his life was turned around, and it made the case. We didn't want to give him steroids, but by golly, they made a difference.
That's interesting. For full disclosure, I coughed for about 3 months, and was prescribed cough mixtures by my GP. I mean, this was quite a long time ago. And having done a specialist respiratory intensive care job, I missed the diagnosis in myself, which was quite funny, really. I'm sorry.
Yep.
I am actually interviewing Professor Richard Beasley in a few weeks' time, and so we'll go into the advantages and disadvantages of the combined therapy then. But thank you for mentioning that, because I am a firm believer in that therapy. So now another question, really, and that relates to growth in children related to asthma and the asthma treatments. I've always understood and been taught in the past that growth affected by inhaled corticosteroids is a transient effect in children, and that it's not something that persists into adulthood. They usually catch up later. Is this still the case?
Yes, I mean, Mark, the best show in town is the CAMP study, which was a North American study, which has now gone on for many years. Interestingly, the original CAMP question is completely irrelevant, but it has produced marvelous data. So the CAMP data are, on patients who had a fixed dose of inhaled steroids, not like clinical practice where you might actually taper down it. So if anything, they were overtreated. The maximum loss of height over the whole of childhood was 0.5 centimeter. And that's the maximum, and I can be very reassuring about that. What I also do is plot the child on a standard growth chart, and the parents and I can look at it together. Because if that child is not growing well, there's something funny going on. Is there another diagnosis to be made? Am I over-treating the child with inhaled steroids? But low-dose inhaled steroids have a very good track record where growth is concerned.
So would you advise general practitioners and parents to be careful about monitoring growth in their children?
I don't think you need to be excessively careful. I would monitor height. We see our problematic asthmatics every 3 months. They get their height measured every 3 months. I'm not sure whether that's practical in primary care, but a couple of times a year. But plot them on a chart. I mean, parents are familiar with charts. They've got the red book. Every UK parent has the red book with their initial growth plotted out. Just plot it out. There are electronic versions these days, and just to reassure everybody, and also, to show parents that you're taking their concerns seriously. They're not being brushed away as nonsense.
Okay, now we spoke a little bit about treatment. Another treatment that's advocated in the UK by the NICE guidelines is the leukotriene receptor antagonist, montelukast. Now, the American Federal Drug Administration have issued warnings about this drug, and I have colleagues who've had experience where children become mentally disturbed on this drug, and yet we haven't had such a warning in the United Kingdom about this drug. What are your thoughts about montelukast? What's its place in asthma, and what are the risks and dangers?
So if I'm starting montelukast, I always warn the parents about the sort of neuropsychiatric side effects you've described, and the prevalence may be as high as 20%. And Francine Ducharme, whom you well know, tells the story about how she prescribed these to a colleague's daughter, and 2 days later gets a phone call saying, "What have you done? You've turned my little princess into a bitch." And they do have these side effects. In my experience, about 5 to 10% of patients think that's absolutely marvelous. They've life transforming, they're great. The rest just think it makes no difference. I think they're overprescribed. They can be very effective. And again, personal non-practice. One of my grandchildren was prescribed them by his GP. I didn't find out till after he'd started them, and he was absolutely fine and did very well on them. So they can be effective. But I think one thing we've all got to be aware of, doctors are great at saying, do this, do that, do more, do more, do more, and not so great at backing off and saying, let's stop this. This isn't any good.
Okay, so now on asthma outcomes, outcomes like asthma attacks, hospitalizations, and asthma deaths. Why do you think that the UK outcomes are not as good as other countries? In fact, in the case of childhood asthma deaths, we're among the worst in the whole of Europe. Why do you think that is?
There are multiple reasons in my view. The first is the disease is not taken seriously. Anybody can treat asthma. It's fine. It's just not taken seriously. The second is lack of continuity and lack of appreciation that an asthma attack is a serious red flag life event. Just giving 3 days of prednisolone and saying come back in 3 months is not good enough. We know from all the literature that a child who's had a bad attack of asthma will have another bad attack, as sure as God made little apples, unless something is done. So if a child has had an asthma attack, there needs to be a focused look. What went wrong? Why did this child end up on steroids? Is the child taking their medication? Can they take their medication? Is there something in the environment? What did the asthma plan say, and should the asthma plan be changed? It's really important that this is taken seriously. But unfortunately, what usually happens is they rock up to secondary care, they get their steroids, there isn't any follow-up. It's treated a bit like a lobar pneumonia. You know, as you know, Mark, if you have a child who has one attack of a lobar pneumonia, you say, well, I'm jolly sorry that happened, but it's okay, that's fine. It's an isolated event. An asthma attack is not like that. And we've simply got to take them more seriously. And monitor things. As you know, you were one of the authors of the National Review of Asthma Deaths. What came out? Yet again, not enough inhaled steroids, too much short-acting beta agonist. Well, in these electronic days, you can monitor that. You should be able to say how many inhaled steroid canisters are being picked up. How many short-acting beta agonist canisters are being picked up? We've got to take this more seriously, that asthma is a killing disease. It's not a trivial inconvenience.
Yeah, it's very sad, really, isn't it? I must say, after all the work we did with the National Review of Asthma Deaths in the United Kingdom, it's very sad to still be hearing of children who are dying from asthma and the high numbers of children who are being admitted to hospital with asthma attacks. So as we come to the end of this interview, Andy, I'm really grateful for all your time. Thank you very much. And so if you were to sum up with one or two key messages, one for parents of children with asthma and one for doctors who are caring for children with asthma, what would you say are the most important things to think about?
So I think for parents, I'd want them to be saying to the doctor, why do you think my child has asthma? What tests have you done? And it may be the tests have been tried and can't be done, and that's fine, but have you tried? Who is the doctor who is taking overall responsibility for my child's asthma? And if your child has an asthma attack, this is something really serious and it needs to be taken seriously. What's going to be done to prevent that happening again? I think those would be the three questions. I think I'd probably say the same for doctors as well, as to be asking themselves that.
Well, that's a very good place to end this discussion. Thank you so much. I'm really grateful for your time. And just for those of you that are listening, Andy Bush is one of the top experts in the whole world. So it's been a great pleasure and an honor, Andy, for you to join us today in this podcast. Thank you once again.
Brilliant. Thanks, Mark.